Britt, you point out there's like hundreds of steroids, and I always go to this like table that I usually pull up from some online resource because I can never remember, the potency and the strength and what dose it came in. What are your kind of like your go-to steroids in terms of like, this is my weakest one to my strongest one?
Yeah.
And then tell us a little bit like, when do you use them?
Okay. So hundreds is a little bit of an exaggeration, but yes, if you pull up one of those tables, it's a good reference to have and you can access it quickly. So I actually do recommend finding one and having that use available for your use. We have classes 1 through 7, and class 1 is the strongest and class 7 is the weakest. And then we have steroids that kind of run the whole gamut throughout that spectrum.
And the weakest is basically like hydrocortisone 1% that you can buy over the counter.
That's exactly it. Yeah. So there's one steroid that's available over the counter, and that's hydrocortisone. The highest over the counter strength is 1%. You could find it in 0.5%, but most of it, what you see is 1% over the counter. You can get ointment and you can get cream, which we'll go into a little further why that's pertinent, but 1% is the highest. And it's marginally useful for
it's like a moisturizer.
Things. Yeah, it's a moisturizer plus.
Okay.
There's a little extra in there. But the important part is don't be afraid of topical steroids. And what we're going to get into is how do you utilize them by looking at it an individual case and picking somewhere within that spectrum of 1 to 7 to get the best result.
And so on this slide, is this pretty much the way you kind of break it down to your go-to? These are common, easy to find, easy to use, like clobetasol being for your really strong,
right?
Fluocinolone, triamcinolone for your medium potency, hydrocortisone valerate for that, I need a little bump higher than hydrocortisone?
This is exactly it. And these are my own go-to steroids. And you're going to get a different list from different dermatologists based on where they trained and what they're familiar with, what's cheapest at the time, because cost is also very important when we decide on topical steroids. So this is not the end-all be-all list. This is what I use, and it's useful from my standpoint, but there are many other steroids in the same classes that are useful.
I just think it's a good reminder to have that kind of your own list. Just to know, like, hey, look, I got my weak stuff, I got my medium stuff, and I got my power players. And you can choose whatever you want, but that way you're kind of familiar with that one and you can kind of use it on a regular basis.
I agree.
Decision paralysis for me, and thank you for simplifying this because that's exactly what I was. Medium, low, medium, and high. That's all I want to know. Right. That's all I'm going to remember.
Yep.
A quick question about this. Are there like go-to formulations that you will prescribe, or is this something that it's case-by-case dependent?
It really is case by case. In different instances, I have used all of these formulations, and it also initiates a conversation with your patient. There are some patients who are so averse to putting something on their skin or feeling greasy at all that they won't apply it. So of course, it's not going to be good. So you kind of find a balance. And even if I think an ointment is the best for their problem, if they say, I won't apply it unless it completely evaporates and I can't feel it, then I go ahead and I give them a foam or a solution because I know that they're going to get the steroid on their skin. And you have to think about where you're applying it on the skin. Nobody wants to put ointment on their scalp. So if they have scalp psoriasis, you have to think about using a solution or a foam or something that's going to really not affect the way their hair looks or that they're going to have an issue at work, So those are other things you need to think about.
Makes sense.
The last thing to think about with the formulation is that things that are more alcohol-based, so when we're looking at solutions or gels, those are going to sting on skin that is broken down. So if someone has a very inflamed area of their skin, they have fissures or little cracks in their skin, it really burns to put on anything that's not an ointment. I always start with the ointment, even if just for a few days to heal the skin, and then switch them to something that they're going to tolerate for a longer period of time.
The classic example of that is like diaper dermatitis, super sensitive. You put on a cream even sometimes for those kids and it hurts. They'll cry immediately.
They cry like crazy.
Trying to keep it really nice and soothing.
Yep.
Nice.
So now we need to talk about how do you pick somewhere along that spectrum for your steroid. So here we have a list of areas and things that will necessitate a lower potency steroid or trigger you to use a lower potency steroid versus a mid to high potency steroid. So the location on the body is number one. We're looking at areas that are quite sensitive or absorb a lot of steroids. So the face, the genitalia, and the intertriginous regions are areas that we really don't like to go somewhere above a low to a mid potency topical steroid.
And intertriginous area, you mean like axilla and
inframammary,
yeah. So anywhere where the skin folds are touching each other. Okay. The steroid is going to absorb more, and those are areas where you have a higher risk of things like stretch marks or thinning of the skin.
So like the hydrocortisone valerate is the one I think I remember from your original one, is like where you
Yeah,
go?
we wouldn't ever really go above that in general.
Okay.
And that would be just for a short period of time.
What you're talking about, no more than a week or two?
Yeah, a week or two is always safe with topical steroids, but not for long-term use. You don't give a lot of refills and just say, go to town on this.
I think that's a good point that you guys bring up, right? Typically, when I'm using steroids, and I learned this from you, Britt, is I don't really do topical steroids more than 2 weeks. At any type of topical steroid, I won't give them more than they can actually apply in that 2-week period, because it gives it a hard stop to the point where you know within a 2-week period, you're going to be safe. And you're not gonna give them enough where they're gonna just use it works and they're gonna use it forever, right?
Yeah. If a topical steroid's gonna work, it's gonna work fairly quickly, within 2 to 3 weeks. And so you don't need to go longer than that. If they're using it for 6 or 8 weeks and it's not responding, that's the wrong treatment to begin with, number one. And secondly, yes, you start to run into side effects once you get beyond that 2 to 3 week point with the skin thinning, or you can get bacterial infections or yeast infections that will pop up. And so it's always safe to not give refills, to give a small tube, whatever it is you want to cover. We'll talk about the grams of tubes that you would want to apply. But that way your patient can't just use it indefinitely.
Okay.
On the hands, feet, and the remainder of the body that have kind of thicker, hardier skin, that's when you want to be able to use those mid to high potency steroids. And sometimes on the hands and feet, that's the only thing that will penetrate that skin to have an effect. The next variable we look at is how old your patient is. And this really just breaks down between very young and everybody else. So if you're using a topical steroid on a child, you're always going to err on the side of caution and give them something weaker than adults.
Is that just because they absorb better, or because you're worried about the long-term effects for them?
Both. So children being small, they have a higher surface to volume ratio, right? So they have a higher surface area from which to absorb that steroid. Their skin is thinner in general and doesn't have, kind of the wear and tear of life. So they don't have as much protection from the steroid, and they are much more susceptible to the systemic absorption. So they can have suppression of their hypothalamic pituitary axis much more readily than adults can.
They have more systemic absorption. All right.
Then you want to look at the thickness of the skin, and that kind of goes back to the area. So any thin skin, you want to use a lower potency, and thickened skin, whether it's because it's the hands and the feet, or it's thick skin simply from the inflammatory process that's going on, such as psoriasis, you're going to have to use a higher potency steroid. The next variable is the degree of inflammation that you're trying to treat. If you just have a mild rash with mild inflammation, you're going to want to use something that's appropriate for mild inflammation, and that's a lower potency steroid. If there's something that's really rip-roaring and acute going on, something like poison oak or poison ivy, you're going to really want to hit that problem a little bit harder with a high potency steroid. And then lastly is the chronicity of use. So using a lower potency steroid for a longer period of time is generally considered okay, whereas high potency steroids should really only be used in acute flares for that kind of 2 to 3 week period to get that process calm. And then you might want to transition to something lower potency that you can use intermittently to keep it calm. It's always easier to keep things calm, again, dealing with mild inflammation, than it is to get them calm when they're really, really rip-roaring. Now we're dealing with severe inflammation. So all these things kind of tie together when we're deciding in our potency of steroid.
Got it.
I have one quick question about that. In terms of, like we always said, not on the face or the axilla or the genitalia, is that just because, again, the absorption is greater there, or do you just get more of the side effects there in terms of the thinning of the skin is more pronounced on your face as opposed to your hand, or just because, well, you want to look good in your face?
It's both, actually. Okay. There have been studies as to the absorption of topical steroids, and the highest absorption occurs on the scrotum and the genitalia. And it's through the roof compared to the remainder of your skin. So yes, you're getting a higher absorption, which also translates to more side effects because you're having a higher potency there, plus your systemic side effects. And then those particular areas are more prone to certain side effects. For instance, yeast infections that, you're suppressing your local immune system. If you're going to have a yeast infection that occurs, well, where does yeast like to colonize? It likes to colonize in those intertriginous regions, in the underarms and the groin. So your you're putting a steroid on an area that's already prone to those infections, and so you're going to have a higher risk of side effects. On the face, it's kind of twofold. It's what we already talked about, plus there are certain specific side effects you can get on the face. You can get steroid-induced rosacea, or what we call perioral dermatitis, that can occur with chronic steroid use on the face, and that's specific to the facial region. You're not going to get those elsewhere, but those are very difficult to treat.